Hello and welcome to my ophthalmic teacher. We're going to talk about the anatomy of the uvea and classification of uveitis today. So the word uvea is derived from uva, which means grapes, and it is the middle vascular layer of the eyeball. We already know that, right? This is the layer, the purple one, and it is composed of the iris and the ciliary body. See that purple layer? And the choroid, right? That's the parts of the uveal tract. Developmentally, structurally, and functionally, it consists of one tissue, okay? Iris, ciliary body, and the choroid. So a little bit about the embryology. So you see that's the cavity of the forebrain, okay? Prosencephalon, where the eye develops. So the primary optic vesicle, that's an outpouching of the forebrain, right? So the maroon line is the neuroectoderm, and the hashed line is the surface ectoderm, and in between is the mesoderm. Please remember these layers as we proceed. So the lens plate thickening of the surface ectoderm, right? And simultaneously the folding of the, optic vesicle to form a cup happens. And here again, the optic cup has folded and the surface ectoderm has pinched off to form the lens vesicle. And there is now you can see a hyaloid artery supplying the lens in the embryonic state, and here is your surface ectoderm forming the lid folds and the epithelium and all, and this is your neuroectoderm, and this is the complete eyeball. So developmentally, iris in the iris, both the layers of the epithelium and the muscles are neuroectodermal, right? As we can see here. The anterior most edge of the neuroectoderm is the part that gives rise to the iris, right? This part. So what is it making up? It is forming both the layers of the epithelium of the iris and the muscles of the iris. What about the stroma and the blood vessels of the iris? They are formed from the mesoderm. Now coming to the ciliary body in this part, the epithelium is again neuroectodermal, and the stroma, ciliary vessels, and blood vessels are mesodermal. Same for choroid. The stroma, muscles, and blood vessels are mesodermal. There is not much from the neuroectoderm, but then the choroidal melanocytes are derived from the neural crest cells, which have migrated to this region. Okay, so that is the development of the different parts of the uveal tract. Now, let us start discussing each and every part. So the iris, this is the iris, and it is the anterior most part of the uveal tract here. Okay, it has a central aperture, which is the pupil, which is about 3 to 4 mm. The diameter is about 12 mm, and the thickness is 0.5 mm on an average. And at the root, it is the thinnest. So this is the iris root, the part where it is joined to the ciliary body. That's the iris root, and that is the thinnest part. So basically, in trauma, it is this part that the iris tears off from. Right. Now this is the crystalline lens, the space in front of the crystalline lens. This space is the anterior chamber, and this thin space that you see behind the iris and in front of the lens, this is the posterior chamber. All right. And this is the anterior segment, and this is the posterior segment. Okay. Please do not confuse between the two. Now, the macroscopic appearance or the gross appearance of the surface of the iris. So this is the anterior surface. On the anterior surface of the iris, you will first see a clear demarcation, a zigzag line, which is known as the collarette. Now, this zigzag line is actually the thickest part of the iris, firstly, and it is the site of attachment of the pupillary membrane. Right? This is the site of attachment of the pupillary membrane. Now, the pupillary membrane, the structure is usually disappearing by about 8 to 9 months. Right. But sometimes post birth also, its remnants are there and they are seen as the pupillary membrane remnants, basically, persistent pupillary membrane. Right. So that is the importance of the clinical importance of the collarette. And secondly, it divides the surface of the iris into two zones, that is the pupillary zone and the ciliary zone. Now, the ciliary zone has these radial streaks. Okay, these radial streaks are formed by the radially running blood vessels. Then there are crypts. Crypts are basically deficiencies in the iris tissue. Okay, they appear as depressions and they may be peripheral or central. And then there are contraction furrows. These are contraction furrows, and this is because of repeat. These are actually tetanic folds which are developing because of repeated dilatation and constriction of the pupil, right? So these are tetanic muscle folds. And then there is a pupillary zone, right? This is the pupillary zone. And at the border of the pupillary zone is something known as a pigment ruff, which is nothing but a little part of the posterior layer of the iris. So just compare, right? You can see the collarette over here, this thickened this region. This is the collarette, which corresponds to this part. And all the region outside is the ciliary zone. And you see these crypts, these are the iris crypts over here, right? So many crypts. And surface landmarks are much easily seen in light colored iris as compared to a brown iris, such as this one. This is a light colored iris. So you can see the demarcations very, very clearly, right? You can even see the these radial, lines, and you can see the contraction furrows. Now, the posterior surface of the iris. So this is, imagine if you were viewing the eyeball from the inside and looking out. So this is the pupil, and this is the pupillary margin. This is the pupillary margin. This is the posterior surface of the iris, and this is the region of the pars pliccata. Okay, these are basically the ciliary processes which are attached in between these folds, these folds or furrows, which are known as the Schwalbe's contraction furrows. In between them are the ciliary processes. And in between these furrows originate the zonular fibers, right? The ciliary processes are located on the furrows, and in between these furrows are the zonular fibers which give rise to the zonules of the lens. That much about the posterior surface of the iris, not much. And remember that it is darkly pigmented, okay? And it is this posterior surface which continues onto the anterior surface in the form of a pupillary ruff that we saw in the previous slide. Now, having understood the gross structure of the iris, let us talk about a few congenital iris defects. So, aniridia, basically absence of the iris. Now, sometimes it may not be completely absent. So here you see the root of the iris is present, and you see a little persistent pupillary membrane as well, right? The rest of the iris is absent, the ciliary zone and the pupillary zone. And look at this. This is a very nicely, properly, persistent pupillary membrane. So originating from the collarette. So the thing is that it has to start from the collarette and across. Okay. So this is a ppm. Then correctopia. Correctopia means an eccentric pupil. Okay. So a congenital correctopia is usually rare, and it is associated with iridocorneal endothelial syndromes, basically trabeculodysgenesis, which we will talk about in congenital glaucoma. So correctopia is seen in that, okay? And polychoria also. Congenital polychoria by itself is rare. It is seen in association with iridotrabeculodysgenesis syndromes. Then iris coloboma. Now, a coloboma, see, you know that there is an embryonic fissure, right? There is an optic cup, and on the inferior surface, on the dorsal surface, is a fissure through which the blood supply is coming. That is the hyaloid artery. Now, this fissure should close. If it doesn't, it leads to these defects which are known as colobomas. Now the defect, the fissure is all through. It is from the iris to the choroid until the backside. So it may be it may be possible that the fissure is not closed just in the anterior part, and that would lead to iris coloboma. So this is a typical iris coloboma. Typical, why? Because it is usually seen in this location, that is inferonasal. Then another type of iris coloboma could be a partial one, where some iris tissue is deficient. It's mostly closed. Now, if the coloboma or the failure of fusion of the embryonic fissure is there extending posteriorly, it leads to the retinochoroidal coloboma. So you see, even the retina and the choroidal tissue are deficient, not just in the iris, but also posteriorly. So this is the retinochoroidal coloboma. This is also a huge RC coloboma. You can just see the blood vessels, the retinal blood vessels overlying the sclera. Most of the retinal and the choroidal tissue is deficient. This is heterochromia iris, or difference in the color between the two iris. And heterochromia can be sectoral like this also, rarely. Then the same iris defects can be acquired. Like, for example, this is also an iridia, but this is actually traumatic. Some trauma has happened, and you can see very well that there are iris pigments on the surface of the lens, which has developed a cataract. So this is a traumatic iridia. Then traumatic iridodialysis, where the iris has got torn from its root, which I told you is the thinnest part. This is again a traumatic aniridia, and you see this is the entry wound, right? So traumatic aniridia, and the same aniridia which is repaired by a prosthetic lens. So nowadays for treatment of aniridia, there's these iris prostheses are available, which are made up of some biocompatible material and behave like the iris. Now coming on to the microscopic structure of the iris, right? So 4 layers starting from the anterior side. This is the anterior limiting layer. Okay, and it's made up of melanocytes and fibroblasts. It is just condensation of the stroma. It is not either endothelium or epithelium. And this layer is responsible for the color of the iris. Now, why is it responsible for the color? Because the melanocytes are accumulating just below this condensation, especially in brown and black iris. Then comes the iris stroma. So the stroma makes up the bulk of the iris, right? So this is the stroma. This is the condensation of the stroma, or the anterior limiting layer, as we choose to call it. Iris stroma is made up of loosely arranged collagenous tissue, a few muscles, and blood vessels. Basically, the bulk of the iris is the stroma. All the structures are present in the stroma only. What muscles are there? There is sphincter pupillae. Sphincter pupillae causes meiosis. It is a 1 mm broad circular smooth muscle band which constricts the pupil. So this is the pupillary part, and this is the band. It's in the form of a circular band around the pupil, and that is your sphincter pupillae, supplied by the parasympathetic nerves and responsible for meiosis. Then the other muscle is the dilator pupillae. Now this runs radially like this from the iris root towards the pupil, and it dilates the pupil, and it is supplied by the sympathetic nerves. Then two muscles done. Blood vessels. Blood vessels also form the bulk of the stroma. So they form two circles, okay, major and minor circle. Major arterial circle is somewhere over here at the iris root, from which blood vessels travel radially and form another circle around the pupil, which is known as the minor arterial circle. Then other cells are melanocytes, lymphocytes, fibroblasts, and macrophages, which are dispersed in the stroma. Now, anterior epithelial layer. So you see, this is the anterior part. This is the pupil, and this is the posterior part. This is the front. This is the part that is in contact with the aqueous. Why is this happening? Is because of the folding of the anterior edge of the optic vesicle. So it folds on itself, right? That is why we expect the epithelium to be present anteriorly, but since the anterior part of the optic vesicle has folded on itself, this epithelium becomes posterior, right? And there is nothing anteriorly but just the stroma. So this is the reason the epithelium of the iris is actually present on the backside. Also, developmentally, it is continuous with the layers of the retina. So the anterior epithelial layer is nothing but the anterior extension of the pigmentary epithelium of the retina and the ciliary body. This is the anterior epithelium. It lacks melanocytes, and it has basal processes which gives rise to dilator pupillae. So dilator pupillae is a type of modified smooth muscle which originates from the anterior non-pigmented epithelium of the iris. And the posterior pigmented epithelium of the iris, that is the posterior epithelial layer, is nothing but the anterior extension of the non-pigmented epithelium of the ciliary body. And it is this layer which travels a little anteriorly and gives rise to the pupillary ruff, which is visible on the slit lamp. So the figure A here is just a revision of whatever we have read, okay? So the macroscopic structure of the iris crypts, these are the region of the iris crypts. Basically, most of the stroma and the anterior limiting layer is absent. So these are the crypts. Then anterior leaf, posterior leaf is basically nothing but that is anterior limiting layer plus stroma as the anterior leaf, and this is the posterior leaf with the muscles and the epithelium. You know the collarette, you know about the ciliary portion and the pupillary ruff. So this is just a revision. Now magnify this and look at it over here. So you see the two epithelial layers, okay? So the posterior epithelium is the one that has the melanocytes and this is pigmented. So the posterior epithelium of all iris, whether blue or whatever, is black or darkly pigmented, okay? As you see, as we saw the diagram of the posterior surface of the iris. The color of the iris is actually derived from the anterior limiting membrane. How? You see the pigment cells accumulate just below this anterior limiting membrane, and this is responsible for the color of the iris. Okay, the pigment cells below the anterior limiting membrane. And the rest of it is just the stroma with its blood vessels. So that's about the ultrastructure. And see, this is the iris vessel. So there are refractile collagen fibrils around the iris vessel. Basically, all this is just collagen in which the blood vessels are running. So this collagen, sort of surrounds the iris vessel, and that's that. Below the collagen are the fibroblasts, and below the fibroblast is the endothelium, and this is just the lumen of the blood vessel, right? So this is the structure of the iris vessel. So that is the structure of the iris in detail. Now, moving on to the ciliary body. So ciliary body is basically the forward continuation of choroid at the ora. You see this triangle over here? This is the ciliary body. This is triangular in cut section. The outer part is lying against the sclera and the inner part is in contact with the vitreous, right? This part. Now, the inner part is again divided into two parts. The pars plicator. This is the pars plicator and it's the part that contains the ciliary processes. And the pars plana, which is the flattest part of the ciliary body. And it is located about 3.5 mm behind the limbus, right? Where these processes end. This part is the pars plana. This is the pars plicator. Why am I telling you about the pars plana and placata is that in retinal surgeries we need access to the vitreous, right? And we can't just poke a needle into the eyeball just like that, just anywhere. There are such important vital structures. So whenever we put a needle or a probe into the vitreous cavity in cases of retinal surgeries, we do it at a distance of at least 3.5 mm from the limbus. Why? Because it is the surface landmark for the pars plana where no vital structures are present. If you go anteriorly, you're going to damage the pars plicator and subsequently the ciliary zonules, and you're going to damage the lens. If you go posteriorly, there is retina ending over here. The ora is somewhere over here. So you're going to damage the retina. So it is only in this region that we can access the vitreous. So that's the clinical importance of pars plana. Where is it located? 3.5 mm behind the limbus. A microscopic structure of the ciliary body. Now just pay attention to this triangular part over here. Okay, the ciliary body is a triangle, right? The bulk of it is made up of muscles. There are three groups of muscles. This one, the outermost, is the longitudinal muscle. Okay. Now this structure over here, remember there is a structure in the sclera known as the scleral spur, which is just a shelf-like structure which is jutting out from the inner aspect of the sclera. It is this spur-like thing which gives attachment to the ciliary muscles. So there are three ciliary muscles, as I told you: the longitudinal muscle, the oblique muscles or the radial muscles, which are at 90 degrees to the longitudinal muscle, and a circular muscle whose cut section we see here. So it is the longitudinal muscles which are, mainly responsible for opening up the angle, okay, involved in the angle in the aqueous outflow dynamics. And the radial and the circular muscles are mostly involved in accommodation of the lens, right? So these are the three groups of muscles which form the bulk of the ciliary body. If you look at the layers, or rather the microscopic structure, you will see that this is the ciliary body, right? So there is a thin space here. This is known as the supraciliary lamina. It consists of pigmented collagen fibers. It continues as the suprachoroidal lamina and anteriorly as the anterior limiting membrane. Nothing, it is just the connective tissue, a space in between two different layers. The bulk of the stroma is made up of muscles. Just like in the iris, the bulk of it was made up of blood vessels. Here, the bulk of the stroma is made up of ciliary muscles, which are of three groups, which we have talked about. Nerve supply of these muscles is from the ciliary ganglion, and the stroma, it contains the major arterial circle of the iris at the root of the iris. Okay, over here we already discussed about that one. So these are the layers: the supraciliary lamina, the stroma consisting of the three groups of muscles. Next we have the epithelium and the internal limiting membrane. So looking at the epithelium, there is a layer of pigmented epithelium, which is the forward continuation of the RPE, and it continues as the anterior non-pigmentary epithelium of the iris, right? So anterior non-pigmented epithelium of the iris becoming the layer of pigmented epithelium and continuing posteriorly as the RPE, right? What about the neurosensory retina? The neurosensory retina is continuing forward as the non-pigmented epithelium of the ciliary body and then continuing as the posterior pigmentary epithelium of the iris. Now, all these layers, the arrangement of these layers is basically because of the folding of the neural tube. Lastly, the innermost layer and the transparent layer is the internal limiting membrane. And this is the forward continuation of the internal limiting membrane of the retina. It's a transparent layer just over the epithelium. So that is your ultrastructure of the ciliary body, or the microstructure of the ciliary body, consisting of the 5 layers. Now looking at the ciliary process in detail, these processes are basically finger-like projections in the pars pliccata, about 70 to 80 in number, 2 mm long, 0.5 mm in diameter, and they secrete aqueous humor. Which part of the ciliary processes secrete aqueous humor? The non-pigmented epithelium of the ciliary processes secretes aqueous humor. This non-pigmented epithelium, along with the tight junctions in the capillary endothelium of the iris vessels, these junctions together forms the blood aqueous barrier. Important question. Now coming on to the last part, that is the choroid. It is the posterior most part of the uveal tract. Inner surface is smooth and in contact with the RPE. Outer surface is in contact with the sclera. This is a picture of a detached choroid. Okay, normally you cannot see choroid as being separate from the retina. They are in close apposition. So this is a detached choroid. I've just put a picture to make you understand what the choroid looks like. So it is a brownish convex structure. The thickness is 0.2 mm to 0.1 mm and it is a highly vascular middle coat. So again, coming to the microscopic structure. So we've seen the gross and the microscopic structures of all the parts of the uveal tract now. So discussing the last one, that is the choroid. From outside to inside, the suprachoroidal lamina, also known as the lamina fusca, and it is in continuation with the supraciliary lamina that we just saw. It contains a long and short ciliary vessels. So the blood vessels are traveling in this particular layer, suprachoroidal or the supraciliary lamina. Then comes the stroma, which we know is made up of blood vessels mostly. So there is a layer of large vessels. Then there is a layer of medium vessels, the Sattler and the Haller's layer. And finally, there is a layer of choriocapillaries. These little blue vessels that you see over here, these are the smallest and they are the choriocapillaries. It is a very rich capillary network which supplies the RPE. This is the RPE. So it supplies the RPE and the outer layers of the neurosensory retina until the outer nuclear layer. And lastly, there is a basal lamina or the Brooks membrane. So this is the Brooks membrane. It is the layer between the choriocapillaries and the RPE. RPE technically becomes a layer of the retina, right? So between these two structures, the choriocapillaries and this retinal, the RPE, is a basal lamina, which is the Brooks membrane, which is the last layer of the choroid. So electron microscopy shows that the Brooks membrane, this blue line that you see over here, it is actually a 5-layered structure. Let's not go into details of that. Remember, with advancing age, lipofuscin deposits appear between this Brooks membrane and the RPE, and these deposits are known as drusen. So these are drusen. These deposits are located between the Brooks membrane of the choroid, that is the outermost layer of the choroid, and the RPE of the retina. So that's drusen, seen in dry age-related macular degeneration. Now coming to the vascular supply of the entire uveal tract. Okay, so it begins here at the bifurcation of the common carotid artery. This is the internal carotid going upwards, its various segments. It gives rise to the ophthalmic artery, and the ophthalmic artery gives rise to all the other branches which are supplying the eyeball. So one major branch is the central retinal artery, which supplies the inner part of the retina. The outer part is supplied by the choroidal circulation, which is derived from the posterior ciliary arteries. Let's get into a little bit of detail. So carotid artery, internal carotid, ophthalmic artery, three main branches. The posterior ciliary artery, which are of two types, long and short. The retinal artery, which supplies the retina, and the muscular arteries, which are going to the extraocular muscles. Now, the posterior ciliary artery, the long and the short posterior ciliary arteries, they travel forwards and they reach the root of the iris. The short posterior ciliary arteries pierce the globe around the optic nerve and supply the choroid and the anterior part of the optic nerve. Now this figure in red, you can see the density of the blood supply. So choroid is it's the densest when it comes to the blood supply, right? This is the choroidal circulation and you compare it with the retinal circulation, which is far less. So posterior ciliary arteries are contributing to most of the blood supply of the choroid, iris, and the ciliary body, which makes up the entire vascular coat of the eyeball. Now, retinal artery, inner part of the retina, posterior ciliary arteries, choroidal circulation, outer part, supplying the outer part of the retina, and then muscular arteries supplying the extraocular muscles, and these muscular arteries give branch to anterior ciliary arteries. Now, there are four muscular arteries to each of the recti, and each of these give rise to two anterior ciliary arteries except the lateral rectus. So in total, there should be 8, but there are 7 anterior ciliary arteries. So just something to remember. So these anterior ciliary arteries are present in the iris and the ciliary body. They join with the posterior ciliary arteries at the arterial circle of the iris, major and minor. We'll see how. So this is the short posterior ciliary arteries at the back, long posterior ciliary arteries which have traveled forwards. Here, this one's the long posterior ciliary artery traveled forward, anastomosing with the anterior ciliary artery, which is coming from the muscular artery on the muscle over here at the root of the iris. So anterior ciliary artery, long posterior ciliary arteries at the root of the iris forming the major arterial circle over here. See, this is the root of the iris. This is the major arterial circle over here. Anterior ciliary artery and long posterior ciliary artery, right? This is the major arterial circle. From this major arterial circle, a few branches come out. They travel along the iris and form another circle at the pupillary border, and this is known as the minor arterial circle. So major and minor arterial circle are the anastomosis between the anterior ciliary artery, branches of the muscular artery, and the posterior ciliary arteries. And venous drainage corresponds to the arteries, okay, and ultimately goes into the vortex vein, which ultimately goes into the inferior ophthalmic veins. The applied aspect, this one's fundus fluorescein angiography. It is showing you the retinal circulation. Okay, so the bright white colored are the retinal arteries, and the darker ones, the slightly darker ones with the laminar flow, are the veins, the central retinal artery and vein giving their branches. This one's an indocyanine green angiography, which is specific for choroidal blood vessels. So you see these vessels in the background, these are the choroidal blood vessels. They are more vertical and they are thicker and larger than the retinal blood vessels. Okay, so this is a picture of a ICG or indocyanine green angiography. Just a revision, okay? The circulation, the central retinal artery and vein going forwards on the surface of the retina, supplying the inner part. If we're giving off these branches, the long and the short posterior ciliary arteries, the muscular arteries, which are giving off anterior ciliary arteries, which are combining with the long posterior ciliary artery, which was traveling here in the supraciliary lamina and the suprachoroidal lamina, forming a major arterial circle and a minor arterial circle, and the veins following the course and ultimately emptying into the vortex veins, right? So I hope the anatomy is clear to you, as well as the blood supply. Now, just a couple of slides on the terminology about the inflammation of the uveal tract. Okay, so uveitis is inflammation of the uveal tract. It is a non-specific term, and these are the specific terms: iritis for the iris, iridocyclitis for iris and the ciliary body, choroiditis for the choroid, panuveitis if all the layers of the uveal tract are involved. Now, anatomical classification. Now, this is important. Anterior uveitis is when the inflammation of the anterior chamber affects the iris and the ciliary body. So, iris and the ciliary body are actually affected along with the fluid that is in contact with it, that is the aqueous, right? So, if you see carefully, this is the part that is affected in anterior uveitis. So, it's inflammation of the iris, the ciliary body, and the aqueous, right? That's anterior uveitis for you. Intermediate uveitis. Now, this is the part where intermediate uveitis term is used. You see, it's the pars plana, right? So it includes pars planitis, the adjoining vitreous or vitritis, posterior cyclitis, same thing. Hylitis. Hylitis is the inflammation of the neighboring vitreous. So intermediate uveitis is inflammation of the vitreous, pars plana, and the peripheral part of the retina. Retina is in close contact, right? So the peripheral part of the retina, that is somewhere near the ora, is involved in intermediate uveitis. Posterior uveitis is inflammation of the choroid and the retina or both, and it includes everything that is present in the posterior segment, that is the choroiditis, chorioretinitis, retinochoroiditis, retinitis, neuroretinitis, and retinal vasculitis. So basically all the structures in the posterior segment can be affected, and some diseases cause a panuveitis in which a combination of the three is seen. So that was the most important classification for you people. Coming on to the clinical classification, now clinically it can any uveitis can be sudden or it can be insidious based on onset. Based on duration, it can be limited or persistent, and based on course, it can be acute, recurrent, and chronic. We will be talking about the acute, recurrent, and chronic uveitis, the definitions of these entities when we talk about the specific uveitis. And the pathological classification, which is non-granulomatous and granulomatous. So non-granulomatous, KPs are basically keratic precipitates, which are accumulation of the inflammatory cells in the anterior chamber of the eye in cases of anterior uveitis. So they are of two types. They may be granulomatous or non-granulomatous. So this is the pathological classification, right? Granulomatous uveitis is characterized by mutton fat or larger sized KPs which resemble mutton fat, hence the name, and seen in granulomatous conditions like TB, sarcoid, leprosy, and so on. Non-granulomatous KPs are basically fine deposits, whitish, and on the cornea, in the endothelium, and seen in these diseases, Fuchs, HLA-B27, Behçet disease, and so on. So that's the pathological classification. And lastly, there is an etiological classification, that is uveitis following trauma is traumatic uveitis. Similarly, there's allergic uveitis, infective uveitis, and toxic uveitis, right? So you can just go back and revise the presentation on my YouTube channel, My Opthal Teacher, and thank you for listening.